Okay. Jonathan, are you there? I can hear you before I hear you.
Hi, yeah, can you hear me now?
Oh yeah. Okay.
Sadly, my voice is loud enough. You can probably hear me all the way in Toronto without a microphone.
Fantastic. Yeah, we can hear you loud and clear. Jonathan's coming out to us from BC. He discovered his passion for pathology, especially pediatric pathology, during med school. A research project following factors in RB sparked his initial interest. That was followed by like a medical rotation on eye pathology, which just further fueled all of his enthusiasm. Today, Jonathan practices general, pediatric, and perinatal pathology in Vancouver. He's going to share with us what role pathology plays in retinoblastoma. Jonathan, take it away.
Great, thanks so much. So this is a little awkward because pathologists often don't really get engaged with patient advisory or other counsel. So it's really a pleasure to be able to come do this. And I know everyone does their land acknowledgements, but specifically I'm in Fort Langley, BC, which is on traditional Kwantlen territory. So as was mentioned, I'm originally from Manitoba and spent a lot of time there, went into med school, completely undifferentiated, but enjoyed research. And there was a medical oncologist there, Dr. David Eisenstadt, who had a research project that sort of blended that sort of translational aspect of basic science to the bedside. He was looking at factors that go on in the nucleus that might be relevant in retinoblastoma and the developing retina. I enjoyed it, really learned a lot of cell biology, and got really interested in ophthalmology. His recommendation as a basic science researcher said, you know, you like biology, maybe try pathology. And so I went out to Dr. Miguel Bernier's lab in McGill as a med student and did some ophthalmology clinics, but also did his pathology as the ocular pathologist there, and fell in love with it. And so quickly swung around and switched to a residency in anatomical pathology again in Manitoba. That is anything that is removed during a surgery or aspirated, that goes to pathology. So that's what a pathologist does, in addition to what, you know, popular culture identifies as being, you know, people, forensic pathologists or Quincy MD. I might be aging myself with that reference. Then I did a fellowship in pediatric pathology down in Chicago, and I was lucky enough to have the opportunity to do some retinoblastoma assessments with Dr. Baird down there, which was great. And then came to BC Children's and had a diverse sign out. I really like tumor pathology. That's one of my main interests. And I have a particular interest in how different areas across a tumor of what I see on the microscope might have different biologic relevance. And we'll talk about that in sort of the big ideas. And so I was lucky to work at a hospital with Dr. Payton, who we had for generations, I would say, sent out our eyes to the adult hospital. Given my interest in retinoblastoma and the encouragement of Dr. Payton, I worked with an ocular pathologist down at Vancouver General Hospital to repatriate the pathologic assessment of the enucleated eyes and eye specimens in general at BC Children's Hospital locally, which I think has been a success. And so I'm very grateful for that opportunity. Next slide, please. So what does a pathologist do in terms of the care of retinoblastoma? So there's a few terms that as I go through, I'm going to be describing some of the jargon as best as possible. So we are not the ones who remove anything, who do any clinical evaluation, although we do feel that any specimen that comes to pathology is our patient. I see a name on the requisition, but it's my way of interacting with the patient. So we don't have clinics, but we treat it the same way. So we can receive specimens that are either fresh, that means that they just come down from the operating room, or they can come fixed. And the reason we fix tissues is to preserve them, to stop any kind of breakdown so that it doesn't cause any artifacts or changes to what we can see under the microscope. And different hospitals across Canada do different things in terms of how they handle retinoblastoma samples. Our hospital, we receive them fixed because I'll mention about the sampling. Dr. Payton does the sampling directly. Other hospitals, such as Manitoba, send the eyes fresh to pathology, and the pathologist is the one who samples tumor for genetic testing. We do what we call a gross examination. Whoops, sorry. But that another term for that is a macroscopic examination. And so we're not using a microscope. We're just measuring the size of the eye, measuring the length of the muscle associated with the eye, taking a good look at it, making sure that we can orient the eye in the proper 360-degree plane. Then we need to section the eye so that we can put it into cassettes that we then use to fill with wax, make the tissue nice and firm, almost like a candle. And then we can use a very sharp blade to cut something super thin. It's 0.4, or it's 4/1000th of a millimeter. So it's very thin. So we need some sort of rigidity to that. So we put it in wax. What you can see in the top right image is a cartoon diagram of an eye that has been sectioned. This is a representative scale of what we do. We generally try to preserve that we get one large piece of tissue that goes from the pupil to the optic nerve. That allows us to have a good assessment of the anterior and posterior aspects. We also, because we're making such small sections and we need to examine enough tissue, we need to sort of spread out the tissue in other cassettes, and we examine those as well. And those are what we call culottes. And on the image that you can see is it's almost like a half saucer flipped upside down, and we will look at that as well. So we examined all portions of the eye in any enucleation specimen. Then we get down to the microscopic examination, and I'll talk briefly about a couple of the findings in the next slide. But we use the macroscopic and the microscopic examination to report specific elements that are provided, in this case, by the College of American Pathologists, as you can see in the two diagrams on the right. And for those of you, just to provide a description, what I'm showing is a long list of different features that we can identify either microscopically or macroscopically. And it's a bit of an algorithm or a tick box system where when we find certain things, it moves to a different area in terms of how that patient is staged and possibly treated. And that is how pathology really tries to do our clinical examination to help support the examination, the therapy for others. So in the last couple of minutes, if we can move to the last slide. Oh, sorry, shoot, I talk too much, I apologize. What I have here are three images from what we see under the microscope. So in one image, we have a view where we can see the pupil down at the bottom left portion of the image and the optic nerve up at the top right. In the center of the image, we're going to be seeing this purple cluster that is what we call blue is bad. In terms of pathology and simplification terms, that is the tumor. When we zoom in, you can see in the middle image, and I'll describe it here, that we can see an optic nerve coming out of the eye. And what we see in the middle of the image are these blue clusters moving towards the optic nerve. That is a feature that we help provide the ophthalmologist and ocular oncologist to understand how deep the tumor has invaded into the eye. And then in the top right image, we have an extension of the tumor out past the eye and traveling along the optic nerve. Through reporting these different features, chemotherapy may be initiated or additional therapy, such as external beam radiation therapy, may be necessary. And the last slide in the last 2 minutes. This is the exciting one for this group. I have a really big interest in pediatric tumors in general, and one of the things we did in osteosarcoma, which Dr. Galley amongst this group also did a lot of great things for osteosarcoma in addition to retinoblastoma in terms of genes, is what are the big questions? And so looking down to research big questions in retinoblastoma, this is what I, as a pathologist, would want to explore in the next couple of years. We are moving very slowly, similar to radiology. You don't see radiologists with the x-rays that they sort of put up to the light boxes like back in the 80s TVs. It's all digital. We aren't like that in pathology. We're moving that way. But the instant you digitize images, machine learning and artificial intelligence allows you to do some quick analysis on that or some really complex analysis. And I think that's one of the big things coming forward. And in other tumors and other diseases, that's something that's coming about. spatial biology, which means how within a tumor, as I was showing sort of just a big glob of purple, there's actually differences going on. Everything's not the same. The tumor cells aren't all the same. The inflammatory cells or the cytokines, which are the communication messengers in between cells, we call those cytokines, are different. And can we explore individual differences to see why particular areas are dying or spontaneously undergoing what we call necrosis? Spatial biology lets us do that. And that's something that I think is very exciting. And lastly, we are very excited in pathology because we can actually sort of jump the gun on genetics and try to suggest an underlying genetic mutation based on what the cells look like. So whether or not it's a germline retinoblastoma gene mutation, or is there another gene that's involved as listed here called NMIC? There's other genes that could become very interesting. A partner, but it's really different, but it has a similar name. CMYC is actually being found in other pediatric tumors to be a poor prognostic factor independently. No one really knows why. So that would be another thing that I'd like to sort of see in retinoblastoma research going forward, is some of these poor prognostic factors or good prognostic factors that can help guide therapy early on from the pathology point of view. So I apologize for going 1 minute over my 10-minute allotment, but thank you very much.
Jonathan, that was great. Let's give him a round of applause. Okay, well, if you have questions throughout, maybe just write them down, and then we'll save them for the end. We're just going to go through the next three, and then we'll go from there. Our next speaker is Bruce Crooks, over at the IWK Health Center in Halifax, Nova Scotia. He's originally from the UK, and so fun fact there. He loves working with children, and in addition to providing excellent medical care, it's really fascinating to see his background, because it's all about how do we find like childhood curiosity, fun, exploration as we're dealing with all of this. And so I'm really excited to hear about him. He gets, in his bio, it says that he gets silly with patients. I'm curious to hear what that looks like too. But he'll be providing an update about the Children's Oncology Group, about clinical trials currently for retinoblastoma. Over to you, Bruce.
Thanks very much. Hopefully you can hear me.
Yes.
Oh, thank goodness for that. So the Children's Oncology Group, some of you will know about this, but others may not. In the world of cancer, we very often have to work together collaboratively to actually get our research done and to try and move forward with new and exciting discoveries. And Children's Oncology Group is, you can see here, there's a link on the screen there. Can I get the next slide, please, Ivana? And the next one again. You've already heard this one. The Children's Oncology Group is what we call a collaborative clinical trials group, and has membership from about 200 or so institutions right the way across the United States, Canada, Australia, New Zealand. And there's over 10,000, maybe even more, like 20,000 researchers that are actually active members of this. And what we are able to do is we're actually pool our resources. We can pool our thoughts, our patients. We can pool everything together to really push research forward. Because as you know, retinoblastoma, for instance, is a very rare disease. There are 24, 25, 30 cases a year in Canada. If you need to do a study looking at 100 patients, then you've got to wait for years to actually get those. But if you actually collaborate with other people, then you can pull those and get there much faster. The Children's Oncology Group is one of only a sort of a number of different groups who actually do this. And what we do is we do a variety of different types of research and support. Can I get the next slide, please? The first thing that we actually do is it's research. And the research that we do is into what we call epidemiology, which is understanding the incidence of disease and who gets it, where they get it and why they get it, etc. And registries, where we can pool information from people to look at patterns. There's also part of what Jonathan does is helps us with the biology and the tumor banking. So those pieces of eye that get taken out, they get stored down, and we can do research on those. And one of the great things to do is to actually pull those together so that There is a freezer in Cleveland, Ohio, that has something like 200 odd different pieces of retinoblastoma tissue from people who've donated their retinoblastoma. And the same goes for bone tumors or leukemias or whatever else it is. And those are what's called tumor banks. And we can do research very, very quickly if you've got access to all those things. What everybody thinks we do is clinical trials, and we certainly do this, and we do a lot of those, bringing new and exciting developments really from the laboratory and from development right the way up to the patient bedside and towards designing brand new trials and hopefully moving forward into big discoveries of new treatments for things. So that's phase 1, phase 2, and phase 3 trials, which move from the very limited ones to the very big ones of what you think of. We also do things called cancer control studies, which is often supportive care and actually trying to make life better for patients. And the other thing that is also very important, and I'll speak a little more to, is long-term follow-up studies as well. Can I get the next slide, please? Thanks. The other thing that COG does is, some of you may have come across the Family Support book and the Family Support app, which actually provides a lot of information, especially when you're a brand new cancer family, cancer parents, cancer child, that are coming together and you have no idea what it is that you're supposed to be doing. You have no idea what you're facing, and you have no idea what you're supposed to do. This provides some help, some information, and helps to guide you along this path until you become the seasoned survivors that I hope you should never be, but unfortunately we are. We also do guidelines. So there are supportive care guidelines. So this is what to do when somebody's blood counts are down and they need blood transfusions. This is what to do when somebody has pain from mucositis, which is mouth sores caused by chemotherapy. And very importantly, and again, I will talk about this a little later, is survivorship guidelines, which is advice for people and doctors and teams that are looking after people who have survived childhood cancer and now in their sort of their late teens, their 20s, their 30s, their 40s, etc. We also are very important is return of research results. So if you take part in research, and often you never have an idea of what happened to that research, but we actually have an important process whereby when a study is finished and those results become clear and they're published, we actually get in touch with the people who've taken part and say, this is what we found, this is what you helped to discover. And that's really important. And the final part that COG does is it actually allows us all to talk to each other. So it allows me to talk to Ashwin and Brenda and Stephanie in Toronto, to Catherine in Vancouver. It allows us to talk to Dan down in Texas, et cetera, right the way across the world, so that if we have difficult cases, we can come together and talk about it. And Kate is going to talk a little bit about the tumor board later. Next slide, please. COG in Canada. So every one of the major centers actually is a COG center. So if you are associated with any of these hospitals or whatever else it is, you have access through your team to the COG. And as you can see, there's an awful lot of them clustered along that southern Ontario, Quebec corridor, but we're right the way from St. John's in Newfoundland to Vancouver in British Columbia and beyond. And everybody and every child who has a cancer, including retinoblastoma, does have access to this. Next slide, please. So retinoblastoma is a core part of COG. It's not a big one because we're not a big group, but we do struggle to try and find some things to research as well. And really, when COG sort of came together as an amalgamation of some other groups right in the very early 2000s, we developed some treatments and some trials. And the first 4 on there are the ones that we developed originally. And we looked at various different things. So, for instance, chemotherapy for group C and D tumors, looking at upfront chemotherapy for group B tumors. So those are the smaller ones. We also developed a protocol for what we call multimodal, which is chemotherapy, stem cell transplant, radiotherapy, etc., for people with extraocular retinoblastoma, where it's escaped from beyond the eye to other parts of the body. And also extra chemotherapy when people have had retinoblastoma removed and there are some high-risk features like the ones that Jonathan showed as well. Some of those trials were successful, particularly the fourth one, but others didn't really get off the ground terribly well and didn't recruit very many patients. And there are so many reasons for that, in particular because retinoblastoma is such a difficult disease to sort of group all into one, because everybody has their own story. In 2012, when intra-arterial chemotherapy started to become available, we did a feasibility study in that and demonstrated that, yes, it is feasible. But one of the important things that we found is that just using one chemotherapy drug is probably not enough, and you need three. And the current trial that COG has open is one using intravitreal melphalan. So melphalan is a chemotherapy drug, and it's actually injected into the vitreous of the eye to help to treat seeding in people with intraocular retinoblastoma, and that's currently recruiting at the same time. So you may have heard of research in all your different centers and everything like that, but we do come together for this. But it's a challenge to actually get as many people on board with exactly the same protocol at the same time. Next slide, please. COG also does a lot of different trials, and there are sort of these baskets of trials. So, for instance, for people who have cancers that have come back, they can take part in what's called developmental trials. And these are usually for brand new medicines that are coming along. And it allows you to access to drugs, but also for us to study how those drugs affect people and what the right doses and everything are. And even if it's not specific to retinoblastoma patients can take part in a lot of these trials, and that can actually help to push forward research in general as well. Next slide, please. The next part is really probably one of the most important things that you as retinoblastoma families, and particularly with new kids coming along, can take part in. And this is something called Project Every Child. And this has been available for about the last 10 years and really aims to actually capture every single child within the COG sphere, to actually be able to help to involve them in research and to actually learn both from them and for them to learn about themselves as well. And really, there are two parts of this. One happens right up front. And really what it is that we come to a new patient and a new family and say, would you like to take part in this project? Which is really looking at whether or not they can enroll in other trials, but also asking if there is extra tumor left over. If you've had an eye enucleated, if there's some tumor left over, can we please possibly have access to that for tumor banking to learn things about it? And then the second part is sometime later on in your journey, which is looking at the tumor registry and potential to approach people for future trials as well. But probably one of the most important things that come across over the last 2 years is something called MCI. Somebody was really imaginative and called it the Molecular Characterization Initiative. And basically, this is gene profiling. And what we're allowed to do is that tumor that you give to us, what we can do is we can do a huge screen of genes that may be involved with cancer. And currently, this is available for people with brain tumors, with sarcomas, which are bone and soft tissue cancers, and also rare tumors, including retinoblastoma. Next trial, please. And what that does is we look at the genes in the tumor, but we also look at the genes in the rest of the body as well, what we call the germline. So those are the genes that are common to every single one, to see if there are changes. And this is kind of an extension of what we do with a retinoblastoma, but we're only looking at impact genetics or anywhere like that, really at the RB gene itself. You can see on the right-hand side, this is a list that I pulled, and this is every single gene that we look at in this project. So you can see that there's a vast array of different genes there. Most of these will be normal, but some of them will be abnormal. And what this allows us to do is to understand more about the tumor, but possibly opens this up to additional medicines and chemotherapies, et cetera, that can be targets for this tumor, and then hopefully access some of those treatments as well. Also, it also allows us to look at mutations in the germline to see whether or not people do have cancer predisposition syndromes. That's super familiar to us in the retinoblastoma world because of heritable retinoblastoma. But there are many other tumors that may run in families that you just don't know about. And so we're allowed to do this. So taking part in MCI teaches us a huge amount about these tumors, and we're learning all the time. But it also allows you to learn more about your tumor and yourself as well. Next slide, please. finally, the last part is that COG also does follow-up studies, and there are two here that are still open, which are really looking at long-term follow-up. So you can take part in these, and you can be signed up to this after your treatment is finished. And these help to study and understand the things that happen to people after they've had cancer and after they've had treatment. So if you develop a second cancer, or you develop some kidney problems or some liver problems as a result of your treatment or whatever else it is. And then finally, the survivorship guidelines provides a lot of information for doctors and teams who are looking after you. And it actually tells you if you've had this treatment, then you can do this. Then this is the stuff that you need to do. So do you need an MRI scan? Do you need a kidney test, et cetera, et cetera? And finally, we're actually morphing that into something called Passport for Care. And I think my last slide shows you that. And really, this is a web-based initiative where we can upload your cancer treatment into this. It belongs to you, and you can take that and port that anywhere else. It will allow you to access your healthcare professionals closer to where you live and say, this is what they recommend that I need for my treatment. This is what I recommend for my survivorship and to help with my care. And that's something that's becoming available to us as well. So really, there are a lot of things that COG can provide for you. And I've probably gone over my time here, and I was told off for it. I'm sorry, I do talk a lot. Most of us do. But I'm happy to answer any questions at the end of this. Thank you very much.
Wow, let's give him a round of applause. Thanks so much, Bruce. I don't know if anyone else is feeling this, but it was like, oh my gosh, growing up, I don't remember, right? Like, how often can I do an x-ray, right? When I go to the dentist, is that okay? Like, there are so many things to keep track of, and so knowing like survivorship guidelines, that was pretty cool to hear. I know we've been going through, like, we've been sitting a long time, and we do want to get to Dr. Payne in a second here, but can you just do me a favor? Everyone just stand up, stretch for like 30 seconds while we switch over to Dr. Payne, and then grab a seat. So just stand up, stretch, take a little breather, and then just sit right back. I'm going to introduce Kate. I've had the privilege of being Kate's patient for the last like 30 years. And I just found out in this piece of paper that outside of when she spends time with me, she likes to go skiing, she likes to go hiking, she loves classical music. So cool to learn. She's the head of the Canadian Tumor Group, the Tumor Group Chair of BC Cancer Agency. She's an ophthalmologist at BC Children's, and we'll be talking about what's going on, not CRAB, but another group called the Canada's National Retinoblastoma Tumor Board. Please help me welcome Kate.
Good morning, can you hear me?
Yes.
Wonderful, thank you. We've been having a little trouble with sound today. We're a very egalitarian group out here, and we don't have a podium, so I hope it's all right if I'm speaking from where I'm sitting. My name's Catherine. It is a great pleasure to be here with you. Ivana asked me to tell you a little bit about why I do what I do. And what I would say is, this is a picture of me. We may all be able to go faster alone, but we really go further together. And without the patients and the families and my support staff, my absolutely wonderful Grace, amazing Grace, none of us would actually all be here together. I started this journey being associated with retinoblastoma because of a patient who I see is on the chat, so I know that she's participating. And Robin, I'm going to name you because you're public on that. I hope you don't mind. Robin and I met when I was a resident. And I think people are always what make us curious, and then the story behind it. And it's inspiring to me to be at the late stages of my career looking after somebody I met when I was training. That's what the story of retinoblastoma really is about. It is a sort of lifelong journey. I got asked, and I'm always grateful for the opportunity to have to explain something because it makes me learn something. So thank you, Ivana, for asking you to talk about tumor board. In a moment, I will tell you a little more about that. We're in Vancouver. I've spent my practice career here, but I did my fellowship at Sick Kids in Toronto with Brenda and the group there at the Galley Lab. Almost all of whom are new people now, except of course for Brenda. And when I look around at the tumor board, that's a little bit the same way. Next slide, please. These are the people who inspire me. Dr. Lynn Murphy, I got to know when I was training. He was in Los Angeles. He and I collaborated on the West Coast on a few cases. Brenda, who has been visionary and always out there shattering ceilings and just slightly ahead of her time. Dr. Ted Dryja and Dr. Webb Cavaney, who were involved at this exciting juncture when we first knew that this disease was a genetically created tumor. And so much has changed in 40 years, and it's been exciting to be part of it. Next slide, please. I was asked to tell you about the Canadian Tumor Board, but that made me go back and look at what is a tumor board. And so I looked beyond our Canadian retinoblastoma one, and the literature I found said that it's been in place for 50 years. That can't be right. I'm sure it was there longer than that because it was also pretty well ensconced when I started. But the idea about a tumor board is that it actually brings a multidisciplinary team together, not just the doctor who's looking after something or the pathologist who has processed the specimen, but also the imagers, the oncologist, and other experts who may be relevant. Usually a tumor board is case-based. We're talking about how to manage a specific story or a specific stage. And the other tumor boards that I participate in the adult cancers like lymphoma, we may have an hour and they say, we've got 4 cases, go. It can be a really rapid. Is there anything that stands out as irregular? Is there any difference? But each of the people comes prepared, knowing something about the case. That's a standard style of tumor board, and it's usually institutional. In other words, you're working with people who are at your place. It's more than 50 years old, so it always started that way, but we will talk about what's on now. The American College of Surgeons Commission on Cancer actually has the presence of a tumor board as an accreditation requirement. In other words, for an institution to be functioning, it should have a board. This is a checks and balances system is the best way I can describe it, that you have a group making decisions together, bringing up extra ideas, having an argument when they don't agree, which sometimes happens, but then going to search for additional information. It isn't about everybody coming forward with their opinion. It's about evidence-based, and you want the highest quality evidence-based care for that individual. So sometimes what applies to one person may not be identical for the other because of multiple factors: location, other ability to tolerate medications, allergies, family situation, different secondary health issues, but it's an evidence base for that person. Next slide, please. So then I wanted to talk about our national tumor board. As Dr. Crooks mentioned, retinoblastoma is uncommon, about 1 in 16,000 live births or so. And that means about 23 to 26 new cases a year in Canada, or 3 to 5 in British Columbia. So we decided that we should be talking together. And just as for about every other aspect of practice, Brenda has been a visionary. And more than a decade ago, we started talking about how could we have a tumor board rather than just working in our own institutions. So by the end of 2013, we were having conversations that said we should have a national tumor board to network Halifax, Montreal, Toronto, Vancouver, which were the treating centers. And I think Winnipeg joined in partway through that journey. And our request was, how do we do this? The original title was actually Canadian National Retinoblastoma Tumor Board and Study Club. And we created it that way because we thought we should be trying to do both things, managing the cases, but staying up to date. There was a lot of discussion about how you did this nationally. If you work at a single institution, every department will have what's called M&M rounds, morbidity and mortality rounds. You talk about the things that went wrong or the things that were a surprise. That may be a surprise to the general public, but we are, as physicians or clinicians in any aspect, held to account for what actually happens, not what we wish happened. And so we need to be able to talk about those things. Those things are generally discussed in a protected environment. And by protected, I don't mean secret, but by protected, I mean it's really important to be able to tell the truth. And so those discussions are carried out usually under a provision of what would be considered the Evidence Act. I'm not sure which countries are also attending in other places, but I know there are international attendees on this meeting. You may have a slightly different format in your country, but I would imagine everybody has some kind of similar ability to talk together. So before we could get together and have a national tumor board, we approached the Canadian Medical Protective Association and said, how do we do this without getting ourselves into trouble and without breaking patient confidentiality? And we were told that we would be functioning like any other group would be if it was institutional. And because we were rare, being national made sense. And so we extend beyond the treating physicians, but we do it with the understanding that what we discuss is A, for the benefit of the patient, B, for best practice, and C, is subject to confidentiality. The people who attend this group are those people involved in retinoblastoma care. So there are ophthalmologists and ocular oncologists. There are the trainees, residents, fellows, medical students who are involved in the care because they're part of the care. There are pediatric oncologists like Bruce. There are pathologists like Jonathan. There are neuroradiologists. There are geneticists and genetics counselors. There are ocularists. There are sometimes social workers or other people involved with the care. Next slide, please. When we first got together as this group in 2013, we thought we might do data collection, but in fact, our meetings have been more a matter of having the case discussions and education that I was just talking about. This photograph comes from this week. My apologies to my colleagues who I photographed, even though they didn't know it. Our National Tumor Board covers Halifax to Vancouver. That means we had conversations over the years about what time of day to do it, when to do it, and how to do it. I talked about being visionary. Not only was Brenda right about we should do it nationally, but we always have been virtual. So we were going online in 2013. You can imagine that we were talking about where's your video conferencing room and how can you get things going. Nobody had heard of Zoom. There had been no pandemic. And yet here we were doing this way. And our agreement at the time was to meet at least once in person per year. I don't think we do that anymore. We couldn't during the pandemic. We try to meet at a Canadian meeting. But my colleagues in Halifax, we think are in their pajamas, and sometimes they turn their videos off. We can hear their dogs barking in the background, but that allows us to actually be through the clinic in Vancouver and to talk to each other. So we do this on a regular appointed time. We send out a call for what do people want to talk about, and they bring cases. And so this was a case being managed elsewhere. Stephanie Kletke, who's the second from the left on the bottom, gave us a talk about a topic and what was the most recent information about how to do intra-arterial chemo according to the study that Toronto had carried out on a certain number of cases. We have a pathologist on the line. We have another pediatric ophthalmologist on the line there. And the next slide, please. And we show pictures of what the inside of eyes look like. This is Ashwin is from Toronto, and I think the other gentleman is from the East Coast. So we look at the images. We try to have the best conversation we can have, apart from you being there in person. I think this is important for people to know so that you realize the opportunity for having multiple inputs from multiple places and a conversation about the case happens. Trying to describe things to your colleagues means you need to actually look at it and be sure about your terminology and be sure about the findings, and it all makes us pay more attention. Next slide, please. So I've talked about why, I've talked about how spread out we are. Part of our motivation was to say we want Canadians everywhere, not just in big cities, to have the most rapid, best access to the best care. And usually the best care is what's available close. So it can be that somebody will be seen in their local community, plug into Tumor Board and decide, yes, everything can be done exactly where you are. We might have a conversation that says, consider a different option. Or we might have a conversation that says, there is a better option and you need to go to a center that has more tools to use. But it doesn't mean that everybody has to get on an airplane and go to Sick Children's Hospital or go to Moorfields Hospital. And I think that's important to know. And at some point, sometimes we have to send things elsewhere, like to a retina specialist with pediatric experience, who's a retina surgeon. We've occasionally sent cases away out of the country. It's also important for families and for the health system here in Canada, where we can pretty much all access things if it's agreed it's the right thing, to know that this helps us make those decisions, but it also helps us defend why they're being done and go to the funders and say, a group has agreed that this is the best thing to be done. We also get the great opportunity to invite guest speakers to come and educate us. So we have had talks on the pediatric anesthetic best practice for children getting multiple anesthetics for EUAs. We have had Guillermo Chantada, who's currently the president of the International Society for Pediatric Oncology, also happens to be a retinoblastoma expert, to come and tell us about new developments. We have the opportunity here, as I said, from Stephanie, about what's going on in the Canadian scene. We have the opportunity to hear from Jesse Berry in Los Angeles, or from Lynn Murphy and Brenda Galley about chemoplaques. Next slide, please. So new things that come to us. Always, this kind of material is advisory. In other words, nobody is obliged to do something. And then it always comes back to a conversation between the treating physicians and the family members, and things get presented to them. We keep this amongst the medical people because of all the reasons I've talked about. So I think there have been questions about, can a family member come to tumor board? And the answer is that this falls within an accepted pattern of practice. The information can go back to you through the physician bringing it to tumor board. Next slide, please. So this is just an example. It was our agenda in February of last year. This talk gave me the opportunity to go back and look at some slides, and we sometimes have the fun of having things like Christmas wishes or something else, but typically we would have cases. Here there was a cup of tea announcement so that the family grouping could have the company of the physicians, a crab report, and notification about meeting dates. Next slide. And clinical framing will find what's the issue that you should be paying attention to on a particular case. Next slide. Sometimes there's evidence guidance in the literature, and we try to bring all of those things together, but we also find on this one, clinicians who have said, everybody's got a different opinion amongst the experts, what works for this case. And the next slide, please. How does this impact patients? I want to go back to the top 10 priorities for CRAB. And in them, we had improved collaboration as number 8, pathways of care as number 9, and access to care. So I've shown you here the National Tumor Board ones. We confirm our clinical course, create a review, make sure we've got precision about what we do, and sometimes give the managing doctors comfort that other people actually agree with what they're doing and support it. There might be the other recommendations or the other tools. When I went back and looked at the literature for tumor boards in general, what they came out with is the impact of a tumor board to either guide or change management, to decrease wait times. They showed that when things were presented at tumor boards, the gaps decreased, sometimes quite significantly. It also helps us to talk about non-medical factors, both for the patient and the team. What are the practicalities? What stands in the way? What can funders help with? What can your community help with? And the overwhelming evidence that there's better mortality and morbidity when things are managed this way. So this is a wonderful thing to be able to do nationally where you couldn't do it in your own institution. It's not the same as asking for a second opinion. It's actually a management tool. And that is your Canadian system. I'd be really pleased to answer questions, but Tumor Board is a big group. I think there are probably 75 names on the send out, and we keep linkages with the fellows who've been treated who are now practicing internationally. So sometimes people are at 4 a.m. presenting from halfway around the world. I think that's the last slide. Can you just check? Yes, thank you so much.
Awesome, thanks, James. It's striking how many people are on the board. I was like, wow, 75, that's amazing. We'll hold questions and we'll shift into our last panel list, who is actually cross-border. So we're heading down to Wisconsin. Aparna Rama Subramanian is an ophthalmologist at Madison, Wisconsin Children's Hospital. And Dr. Payton had talked about chemoplaque. So Aparna is going to walk us through the results of a chemoplaque trial. Aparna, over to you.
Thank you very much, Jay. So you had a question about who's from Southeast Asia. I'm not from Southeast Asia, but close enough. I grew up in India. Can we start my slides, please? Ivana wanted me to tell something about me. So like I said, I grew up in India. I went into medical school thinking I would go into ophthalmology because my parents are not doctors, but my mom used to organize cataract camps. So I was like, oh, this is really nice. I will go into medicine and go into ophthalmology. I kind of lost track a little bit during my clinical years in medical school because I was really attracted towards pediatric oncology. But then I came back to my original love of ophthalmology, did residency. And when I saw the first few retinoblastoma patients, it made complete sense that this is what I wanted to do. So then I did a fellowship in ocular oncology. I did it at Wells Eye Institute in Philadelphia. And then I did a pediatric ophthalmology fellowship with Children's Boston. So I'm currently at Children's Wisconsin. And thank you very much to the CRAB board to invite me for this talk. Can we go on to my next slide, please? So just to kind of give an idea, not just what's happening in developed countries, but also in low-income countries. In high-income countries, more than 99% of retinoblastoma, fortunately, is localized in the eye. There's just a 0.3% chance of metastasis, whereas in low-income countries, only 50% of retinoblastoma is localized in the eye. This is partly because of delayed diagnosis, difficult access to care, and factors like that, but 50% still is only in the eye. Can we go on to the next slide, please? So this is where the question comes up, why should we consider local treatment? Because again, we want to increase the amount of the drug that goes in the eye, and we want to minimize the effect of chemotherapy in the rest of the body. So the eye, because around 99% of retinoblastoma in developed countries and 50% of retinoblastoma in low-income countries, the tumor is only located in the eye. We're trying to find ways on how we can treat only the eye and spare the rest of the body of chemotherapy effects, both short-term effects and long-term effects. Can we move on to our next slide, please? So let's skip this slide. Let's go on to the next slide. So the chemo plaque, I did it with Dr. Galley. I know, Ivana, you asked me not to call people by their first name. Out of respect, I have a really hard time calling her by her first name, but I can try. So this was done in 2 centers. At that time, I was at Phoenix Children's Hospital, and Dr. Galley did the first 3 doses of the chemo plaque. It was a 0.6, 0.9, and 1.2. And I started with the 1.2 doses, and I went to the higher doses at 1.2, 1.5, 1.8 milligram, almost like a relay race is how we ran the trial. This was a phase 1 trial. I know you heard Bruce talk about different phases of trials. This was a phase 1 trial where we are trying out different doses and trying to figure out what would be the most effective and the safest dose to take it forward. Can we move on to our next slide, please? So total, there were 40 participants, and you can see at different dose levels how many eyes were treated. Majority of the eyes, 37 of 40, had failed previous treatment, either systemic chemotherapy or intraarterial chemotherapy. Intraarterial chemotherapy is where they go up the femoral artery and give chemo only to the eye by giving chemo in the artery that supplies the eye. So 37 out of 40 had failed previous treatment. And in 3 out of 40, this was the primary treatment when the diagnosis of the child was made. The median age was 1.7, but we had a whole range from 2 months to 19 years. Can we move on to our next slide, please? I know this is a very busy slide, but I kind of want to kind of highlight just a few things, because this graphical description, which was again devised by Dr. Galley, really makes it very easy to understand. Can we just click a couple of times, please? Yes, thank you. So what you can see is that the central line you see is our intervention of the chemo plaque, and every dot that's represented to the left on the screen, to the left of that line, are all the previous treatments that the child has had, and then the line is where the chemo plaque was done. So just by looking at it, you realize some of these kids have had extensive treatment, and then after the plaque, the number of treatments is much lower. Then the notation CR means complete response, meaning after the chemo plaque, the child did not have any additional treatment, including things, thank you, including things like laser or anything. The notation DLT means dose-limiting toxicity, meaning there was some effects of the chemotherapy that was seen. And as you can see, just by visualization, just as the drug dosage was higher in the top frame, there was more toxicity as we increased the dosage of the drug. Can we move on to the next slide, please? I'm hoping you are, these images are not off-putting to you. If do, please let me know and we can just go on to our last slide. But I just want to emphasize this. One of my patients, I said the age range was large. This was my 19-year-old patient and friend. She had unfortunately lost her other eye as a child, and she had a recurrence much later in life, which is unfortunate, which was fortunately very rare, but unfortunate for her that it happened when she was 19, and it started to affect her vision. We had exhausted all other resources. And we cannot laser this tumor because it will really affect her vision if we lasered it. So we treated her with the chemo plaque. She's 1.5 years out, and she's doing really well. Can we move on to our next slide, please? So the recommended phase 2 dosage. So we've completed enrollment of our phase 1 trial. The complete trial results are not available at this time, just because all our patients have to be followed for a total of 3 years. Some of our patients have crossed 2 years, but our last enrolled patient has not reached 3 years. That's why we can't call it a completed trial yet. It is still in process. But based on our preliminary results, we have what we call as a recommended phase 2 dosage, meaning which is the dose we found was effective but well tolerated for the eye and the child. And that dosage we found is 1.2 for an older child. And for any child that's less than 6 months, that dosage would be considered 0.9 milligrams. And just in our trial, again, we call it preliminary trial results because not all our kids have finished 3 years. But our preliminary trial results show that at 1.2 milligram, 89% of the patients showed complete response. We call it sustained complete response because it's staying on during the duration of the follow-up. Also, if you remember our second slide, we said why we ventured on this is to minimize systemic toxicity, minimize the drug exposure to the rest of the body. And except for the child, the 2-month-old child, all our other kids, the plasma, the blood level of the chemotherapy was undetectable. We could not detect the chemotherapy in the bloodstream, even at the highest dosage in all our kids except the youngest child. Can we move on to our next slide, please? I'll just quickly go through this. So again, this is a child that had tumor and had what we call as seeds in the eye, but then had a very nice response with the chemotherapy plaque. Can we move on to the next slide? And let's stay on this slide for just a second, because this is a child that I treated from Mexico. And I'm actually logging into this meeting from Mexico. I came to see our sister program in Mexico, and I just saw this child yesterday. He's 2 years out of chemo plaque. His central vision is still preserved. He unfortunately lost his other eye, but 2 years out, he's still doing very well. And as you can see, his central vision is very, very good. Can we move on to the next slide, please? So just kind of to talk about not just what we have, but what it could hold in future. We can try to do some early detection. These are prenatal scans of one of our patients. The tumor was detected at 32 weeks. That on prenatal ultrasound started growing. So we could potentially look to treat small tumors with a very low dose of chemotherapy and not subject these little children to chemotherapy given through the bloodstream. Can we move on to our next slide, please? And again, I am from India, and I have a real interest in global retinoblastoma. This is just to give an idea that the treatment cost, especially when it comes to intraarterial chemotherapy, is very, very high. So when we think about expanding care to other countries, we also want to think about cost-effective, affordable care that is easily given with minimal toxicity, but very good effectivity. So thank you very much for your attention. And I believe that's my last slide.
Awesome, thank you, Hannah. Wow, a lot to unpack, right? Over the past 4 speakers, I imagine you all have tons of questions. Why don't we open it up to anybody, whether you're in Vancouver or Halifax, if you're here in this room. Any burning questions for any of the speakers, whether it's a specific one or all of them?
Francis, are there any questions online? Anyone have a hand raised or written questions?
Yep, there is a written question from Mary.
Hold on, let me pass you.
Thank you. Yep, there is a written question from Mary in the chat, and it says, to Bruce, is there currently a Canadian or USA established survivorship guideline for those who have an RB mutation?
It was approved in the United States.
Okay, thank you very much. Here we go. There you go. My microphone is on. Thanks for that question. So there are the survivorship guidelines that I talked about are not just Canadian. They're available freely to anybody throughout the entire world. And the link that I put on there will take you straight to that. That covers all cancers and also includes retinoblastoma. When it comes to people who have heritable, really part of that depends upon which mutation you have as well. And really some of that guidance needs to come from your genetic counselors and your genetics department. Generally speaking, there are some advice and there are some papers. This is a project in develop. This is really sort of a work in development as to what the best recommended follow-up for people who have heritable cancer syndromes is. And each of them is slightly different. So some of them that you will see, maybe something like P53, they incorporate a lot of things like whole body MRI scans and things like that. The last paper that I saw about retinoblastoma really looks at sort of the cost effectiveness and the chances of picking anything up with a lot of detailed scanning, and really the bang for your buck is actually incredibly small. And so going through an awful lot of treatments and surveillance and things like that is not necessarily in your complete best interests. The advice at the moment really is evolving, but really sort of revolves around a lot of knowledge of your own body and making sure that you know that everything is okay. And if there's anything out of the ordinary, getting it checked out. High risk, high chance of sort of what's the word? It's a high level of suspicion for anything else, and a willingness of your primary care physicians to check things out is probably the most important thing at the moment. I hope that helped to answer.
Yeah, that was fantastic. Thanks so much, Bruce. Any other questions that are burning? Yes. Mike's coming over to you. Yep.
Thank you. This is Helen. Thank you, everyone, for those great presentations. My question is for Aparna. And first of all, a comment. Aparna, that was very, very clear. Very lovely presentation. I think everybody understood. I'm curious what the next phase of this trial is, and if there's any opportunity for patient families to get involved, and how you might see patient families being involved in such a trial or next phase of the research. And in fact, that's a question anyone on the panel could answer. I know Jonathan mentioned spatial biology. How could we begin to get PRAB members involved in studies like that? Or even Bruce for COG, how are patients involved as partners in that kind of research?
Thank you, Helen. Can you hear me?
Yep.
Okay. So for the next phase of the trial, Dr. Galley and we are trying to open up the next phase of the trial, which will be a phase 2 trial, and we would really look at the 2 doses that we think are effective and safest, and we would want to expand the number of patients that get this treatment and have a longer follow-up, so we know more clear-cut results. I think CRAP could hold a huge part, and Dr. Galley can add to that, because I think clinical trial organization and running when it comes to rare pediatric tumors can be tricky, because enrollment is hard, the funding support is limited. So I think if there is a advisory board that's run by families, they can be advocates for newer treatments to be developed and kind of help push that message forward. But for the next phase of the trial, we are collecting patient satisfaction information also. So I think that would help also in the long term, saying how it's not just how the treatment was effective, but how did the family think the treatment was with respect to coping and things like that.
Great. Thanks, Aparna. And maybe before we go to Bruce and Jonathan, I guess that this is just a quick fast follow on that. You showed all the different costs related to other, treatments. What would chemoplaque? What's your guess as to how that might lower costs for treatment there?
I think it would be significantly lower, because this is through a clinical trial. I can't put a number on it, but compared to intraarterial chemotherapy, I think it would be significantly lower. And the other problem with techniques like intraarterial chemotherapy is that it's not just the single child's treatment, but the investment required to get that program up and running is very high. Like I said, I'm in Mexico right now, where yesterday the center did their first intraarterial chemotherapy, and the amount of funding support they needed to get that program up and running was extremely high. So it's not just that number, but what it requires for that program to get up and running, and what it requires to train specialists to do procedures that are more invasive. That is a more invasive procedure. The chemoplaque is less invasive, and it is easier to perform and train people to do it.
Great, thank you, Aparna. Jonathan, Bruce, anything to top up on from Helen's comment or question earlier?
I'll jump in real quick and say, as someone who doesn't directly engage with patients, but one of the big things that I know helps support research and work in this area is patient advisory councils, in terms of ensuring that when projects come through, they're reviewed by members, patients and family members with lived experiences, to ensure that we're doing proper research that is within the realm of what patients would want. Also, patient advocacy in terms of pushing to say, I would like my tissue donated for research. I know we get those requests quite often from the oncologist saying they're signing up to do extra things outside of the general tumor bank, which is great. And lastly, as I mentioned, some of these big ideas that need to come down the pipeline require collaboration with patient advisory groups and research advisory groups to help find funding sources for things that otherwise, I do off the side of my bench with a couple of researchers at the Research Institute, where we just sort of pool our budget to just sort of explore things. Some of those esoteric funding mechanisms could be very beneficial, and are often driven by patients. Those are my 2 cents.
Patient advocacy, definitely a core part. Bruce, Kate, anything to add before we shift on?
Here.
I think Aparna and Jonathan have said most of it, but really it's a willingness to be involved. And I think probably everybody thinks about a clinical trial. You look very, very specifically at this one piece, which is what is the chemoplaque actually going to do? But there's an awful lot more that runs alongside that. So if there's opportunities to put quality of life stuff in, because the quality of life of a kid and a family, just having a little bit of a chemoplaque stuck on is significantly better than traveling to another center for the intraarterial chemotherapy and the risks involved with that, or coming into your local center and having chemotherapy and then potentially coming in because you've got a fever and an infection and and all sorts of things like that. So the quality of life part of it, to advocate for that, I think is really important. And the financial impact and sort of the financial costs and the emotional costs of going through something like treatment, I think is very, very understudied, understated. And Mauj here is very interested in the qualitative results of research that that CRAB in particular looks at very, very closely. So really sort of advocating and getting involved, getting hold of your local centers and saying, is there anything that I can possibly do to help?
Yeah, great. Thanks so much, Bruce. We've got a comment from Brenda here in Toronto.
Yeah, I'd just like to say that this meeting is absolutely unbelievable. Now I want to cry. So thank you to all of CRAB who put this together today. And I can't name everyone here because I can't remember any names, but it's absolutely fantastic. But just as an example, on the last questions about chemoplaque, it will go into a phase 2 study that's just being put together barely. And thanks to Bruce's contribution, it probably will be run through the Children's Oncology Group. And it will bring, and we have the opportunity to bring CRAB right into that protocol.
Yeah, awesome, awesome. One thing that strikes me, and then maybe we'll just take one more question and then go to break, is that like you're already doing the work, right? You're already connecting with community. You're already working in Wonder. You're already evolving the vision, and like you might have heard it naturally come out of Kate's mouth earlier, but like Brenda, to your point, like man, Brenda shatters ceilings. I was like, cool. Like, let's keep doing that, right, with the tumor board. And so, awesome stuff. One last question, and then we'll shift break, either online or here in this room.
Vancouver, anybody have questions there?
Vancouver's muted, is that what you said? Vancouver, you're muted. Come off mute.
I think we've muted them.
Always muted.
Do you want me to touch something? Yeah, let's go for it.
Okay, well, we're waiting from Vancouver, and then Halifax, get your question ready, and then this is our last 3.
Perfect. So this is a question from online, and it says that a common theme across all the talks is being disruptive and pushing boundaries, challenging convention in care. Why does this appear to be so necessary in RB, and how can we help advocate to support with this?
Yeah, how do we, any takers from the panelists? How do we continue, why is it so important to challenge convention and push for disruption in care?
I'll take a swing as someone from the pathology side again. When you're dealing with a rare disease, it's very tough to rally together the volumes needed to make change. And so I think extreme pushes, such as pushing through the chemoplaque through COG, that will, if you didn't advocate and push and cause ruffles at COG to get this pushed through as a phase 2 trial, it won't get done just because of the volume. So I think that it's an extra set of lifting that has to be done by both clinicians, families, and patients and families with lived experiences. So I think, it's a common theme because that's the only way we're going to see changes. That's my point of view.
Yeah, thanks, Jonathan. Also to advocate, medicine is big and it's unwieldy, and often there's a lot of inertia in healthcare in that this is the way that we've always done things, this is the way that we do things, this is the way that it will be done. And there are a lot of disruptors in there, but it's a superhuman effort to try and make your point of view come across, to say, something, this isn't always the right way to do things. We should change things. We should try something different. We should come things up. Retinoblastoma has actually been very, very innovative in so much stuff. Since I started this, I've seen chemotherapy come in. I've seen subtenon chemotherapy. I've seen intravitreal chemotherapy. I've seen intraarterial chemotherapy, plaques, etc., etc. All the advances that have come, particularly through the ophthalmology world by disruptive people, and to really push this. And I think that CRAB has been very disruptive by challenging that the research teams know the best, and that we do that, and the people who take part are sort of more passive bystanders, and to actually bring people into that, and sort of to have patient advocates and family advocates in there is actually really, really important, because it makes you challenge, and it makes you think about doing things differently.
Yeah, wow, powerful. Actually, while we're with you, Bruce, anyone in the room in Halifax have a question or comment?
Could I make a comment? Can you hear me in Vancouver?
Oh yeah, Kate, you're off mute now.
I appreciate what's just been said, and I'd like to reframe it and say we've got an amazing opportunity. And if we start where Jay took us, that it's about community, and that we can't really do it alone. The idea of being disruptors, of actually being a family and survivor group advocating for things, puts this group a little bit on the leading edge. And I don't think for any one person, the heavy lifting that's required to make change is ever an easy thing to do, whether you're a professional or whether you're somebody affected by a disease. But I think the opportunities here now, with all the disruptive things going forward and the opportunities to network, actually make it hard to turn down. This is children's disease. This is genetic disease. This is oncology disease. And so it crosses a number of boundaries and fields, and it doesn't allow us to be pigeonholed very well. And maybe that's our kryptonite. Thanks.
Yeah, it's fascinating, right? The complexity of like moving cross-functionally across, area actually is also what leads to the disruption too. So there's a bit of a paradox there. While Vancouver's off mute, Vancouver, Halifax, any questions going on that are burning? Comments? All good? Okay, great. Ivana, I think we're good to head to break. Maybe. I'm going to pass it back to Ivana. All right.
Okay, thank you so much. I just wanted to add really quickly to that conversation that why do we want to disrupt and create wonder and move things forward is I'm a parent, so my son was diagnosed almost 11 years ago in August, and I've seen very big differences from attending conferences and how retinoblastoma has moved forward. And as Aparna has shared some of the statistics, it's not the same across the world. So as a parent, I would love to see that we continue moving forward and the future generations have even better experiences and more programs and support and different perhaps medications and care and continue along this path that we're going. And that then we can share these or somehow ensure that the experiences across the world can be similar so that our fellow parents in another part of the world who are experiencing the same that we are can have the same outcomes that we have. So we do need to keep pushing, and we do need to keep this wonder going and keep asking questions and being involved to make sure that flow keeps happening. And we have people like CRBS who help advocate on behalf of parents and patients and other groups, and of course our health professionals and researchers who are very passionate to support this research and retinoblastoma moving forward. So thank you very much. We have had great conversations which have moved us a little bit past our time. So if I could ask everyone to take a 30-minute break. Any parents with kids in the Child Life program, please check in and feed them if they are hungry. And then bring your lunch here. We can continue for the day and we will end on time. So 30 minutes, and our Halifax and Vancouver, please, leads, please help bring the folks back in 30 minutes. So that would be like quarter after my time.